How do you change the healthcare culture? What are rapid cycle improvements? And how does cabbage create change? Welcome to the Transformative Healthcare Podcast. I'm your host, Todd Chobatar, and I serve as publisher and editor-in-chief of AdventHealth Press. We're trying something a bit different with this series. We often create podcasts after a book is released, but this time we're going to share the book's concepts before they're published as a work in progress. Our authors, Dr. Jeffrey Kuhlman, Senior Vice President and Chief Quality and Safety Officer for AdventHealth Orlando, and Daniel Peach, Director of Clinical Transformation at AdventHealth Orlando. Today's episode is entitled An Unstoppable Alliance, Culture and Strategy. Now let's join Jeffrey Kuhlman and Daniel Peach as they discuss rapid cycle improvements, sustainable change, and cabbage.
As a parent, I wanted to have my son take out the garbage regularly. So I thought about it. I promised him, I'll give you $1 every time you take out the garbage. And it worked.
He didn't negotiate for more then?
Well, I was proud of my strategic plan. Then over time, I realized he wasn't really learning the importance of helping the greater good of our family. Taking out the garbage was just a short-term means to an immediate result, a buck. So it kind of sounds like rapid cycle improvement.
Yes.
Yeah, so rapid cycle improvement, you identify the problem, you try to find a way to solve it through the routine, and that's kind of classic performance improvement or PI strategies. So PI strategies, I think, often work for rapid cycle or short-term improvement. I'm not sure that, I think all of us have been involved with PI projects, and you go back months or weeks later, and all the advantage that you got has fallen by the wayside. So there was no sustainment trend. So transformation requires much more.
Yeah, I would completely agree. I mean, if we talk again about that widget making, that where we bring in all of those classical industrial type processes that are there, and they're great on widget making. You can change that industrial process. You can speed it up. You can change the assembly practices. You can change the colors if you want. We make rapid cycle improvements in healthcare all the time. I mean, if you look at just changing the antibiotics that may go out there, or adjusting slight costs because of it. So they're sort of the examples that we tend to use. And there's some benefit to those. We can get those there. But if we look at those sort of multifactorial improvements, if we look at those clinical transformations that we need to make, those solutions have to reach across a multitude of disciplines. We tend to do this, and we forget sometimes that we do this, and we work as a team. Prime example is looking at something like sepsis.
Yeah. Sepsis, I think, is a classic example. Sepsis is the overwhelming infection of the body and cascades into where the vascular system can't sustain life. So you go into septic shock. Sepsis by far is the number one cause of in-hospital death in the U.S. and in Western civilization. Half of sepsis can be like a respiratory pneumonia.
Yeah.
But sepsis also can be the exotic, can be Ebola, of a bloodborne virus.
It was the old blood poisoning that people used to
Yeah.
look at, and it's one of those that's all encompassing, not just that it's systemic in the body and causes problems, but it's all encompassing in a healthcare practice that you need a multitude of people to get involved in it. And that was one of the areas that we look and we continue to look at. This is not a solution for next day. This is not changing an antibiotic and magic happens and you're done.
Yeah, but I think if you look at in healthcare, what they had tried to do for sepsis is throwing the kitchen sink at it. So lots of little different PI projects, and they did have some rapid cycle improvement, but the sustaining part of it was non-existent. So
yeah, and we'd focused again on, we were given metrics that you had to accomplish. The government had an ideal sort of parameters they wanted you to work to, and there were time limits that were put in there, and there were certain elements that you had to encompass within a certain period of time, but forgot about that, in some respects, that patient interaction, about who the patient was, where they came from. Did they have Ebola?
Yeah.
Did they have pneumonia? And how do you tweak that on an individual basis to solve?
yeah, so I think the improvement has to come from it's more multidisciplinary. So, for example, I think we'll learn more about it later, but for sepsis, it's not just at the point of care that you got to do the right thing.
No.
It's taking that patient that came into the emergency department with an overwhelming infection, but actually moving the recognition and the starting the treatment
Absolutely.
to maybe when they got picked up on the street or the facility that they're at or their home, and having the paramedics and the EMTs who are able to recognize those first warning signs and actually starting the fluids and taking some innovative ideas with equipment and practices they already have, and so then having a sepsis alert, but not just an alert, but starting the treatment. And then once they're in the emergency department, it's not just a doctor goes to his computer and does an order set or a power plan, but sepsis has a higher mortality rate than a heart attack or a stroke.
Yep.
And, we move mountains and fly helicopters when we're treating those. So jumping on sepsis as soon as it's recognized, time zero, with doing the appropriate blood cultures, doing the blood test, that's the lactate level, starting the appropriate antibiotics, and there's been 0 lives saved by ordering an antibiotics.
Yeah.
The medicine actually has to be dripping into the veins and going through the circulating through the body, killing the organisms causing the overwhelming infection. And then just as important as the antibiotics is fluid resuscitation. So doing, many doctors were always afraid, we're going to put them into heart failure or we're going to put them into kidney failure. Can their body take the overload of fluids? And the answer is, they're going to die if you don't fluid resuscitate them and keep their organs perfusing. So it's more important to give them the fluids for septic patients. And if you top them off a little bit too much, we certainly know how to treat that.
And that sort of illustrates one of the points as well, is that it's that empowerment that runs right the way through. It's don't just allocate one task to one person. Don't look at it in a completely focused format. It is a team game. And that team also involves the patient. And being able to empower right from day one. So if the patient was in a skilled nursing facility or they were picked up on the side of the road by the paramedics, having them have the opportunity to say, look, you know what, this is not great. And being able to give the heads up, it's a bit like pulling the fire alarm. And you can sit in a room and smell smoke, and you can decide that I've got 2 courses of action. I can get up, sneak out the door, stand outside, and watch the whole building become engulfed.
Which may be good for you.
Yeah, you get away. Hey, that's fine. But then you can do the right thing. And you can stand up, you can pull the fire alarm, you can turn to everyone and say, look, I smell smoke. We need to do something. Get everyone out. And even if it wasn't a fire, at least the course of action has started. And if you do need to take action, everyone's part of that team. Everyone knows we've got a problem. Everyone knows we're going to deal with it. And the training and the skill sets that people have acquired over the years really then comes into play. So you're not then allocating one tidy task for each person. The whole team gets embroiled in it, and they then start to look at where the problem is and to resolve that issue and to all fight with the same end, and including the patient in there.
Yeah. So I think pulling the fire alarm is, you don't necessarily have to see a flame burning. You can like smell the smoke.
Yeah.
Or you can just suspect that there's a fire somewhere. So for sepsis, if you know that they have sepsis, that's seeing the flame, or if you just suspect that they do, then pulling the alarm is actually starting that sepsis power plan, that bundled set of orders. And it's not just for you to do the right thing, but it actually sends the communication to all the different team members so they can do their job in the department that you're at. But most importantly, what we found is that also continues the handoff to the inpatient team or to the critical care team up in the ICU. And the ability to just do your job, it makes me think of whether you're a Patriots lover or a Patriots hater, those tend to be the kind of the passionate sides of the aisle. If you think back to the Super Bowl a couple years ago, where they were down deep in the weeds in the fourth quarter to the Falcons, and Tom Brady. He didn't do a passionate speech to everybody invoking Vince Lombardi, but he just said, do your job. And so each player did their job on every single play, and I think the rest is history. So same thing in transformative healthcare. It's everybody doing their job. It's listening to the front line, empower the front line, hold them accountable with reasonable measures, and that's the lasting change. It's not rapid cycle, PI, short-term improvement, because there's no sustainment plan.
No, and what you're doing is that empowerment is correct. You're creating that cultural change, that it's not about me just doing my job and creating that short cycle return. It's about me doing that as part of the big team, as creating a cultural change that if I do my job, I'm looking at that bigger picture of what else is encompassed in there and how can I assist and support everyone else, whether it's with sepsis right at the very beginning out on the street or right the way through into ICU. Everyone has been part of that long part of the team and encompassed within that. And when you have that change in culture, you then reap the big benefits. You then don't just get that short cycle change where everyone jumps on board, they do it for a while, lose focus, drift back to where we were. You then get that sustained, that long-term result that you're looking for. And that's hugely important in medicine now, because as we said earlier on, you get into a cycle of making rapid change. You do these short cycle changes. We reduce the thickness of the material. We get it out the door a lot faster. But then are we missing other things by doing that? Whereas if we looked at it all-encompassing and we change the culture that everyone's involved in there, then we start to make that role.
Yeah, so the most sustainable type of improvement is when there's a change in the culture. When culture and strategy actually work together, then you reap both short-term and long-term results. It kind of makes me think of another transformative project, Cabbage, coronary artery bypass graft.
Yeah.
Is to me an example. If you have culture and strategy working together, the change is dramatic.
Yeah.
For CABG, you take a cardiothoracic surgeon who's trained 10 years before they're allowed to go off on their own, which is probably a good thing. So at our hospital, we have 10 cardiothoracic surgeons. They all do about at least 2 a week. Of the isolated CABGs, they do other open heart procedures. And if you look at the patients that they do the CABGs on, it takes about 5 hours to do the surgery.
Yeah, between 5 and 6 hours.
Yeah,
Right,
and there's very little variation. The variation of the intraoperative time is single-digit minutes. So the technical part of it is there's very little variation. Others had, other healthcare systems had focused on, Lean or Six Sigma for the intraoperative portion, and what we actually found is the swing and the variation happens in the pre. So the days before you have the operation, the wide variation in stopping blood thinners and making sure their nutritional status is optimized, and assessment of their frailty.
Yeah.
And that's where the wide variation. So getting the surgeons and the nursing staff to discuss, hey, what's the optimal way that we can do to make sure that we're lining up give the patient the best chance going through this very complex operation.
You mean actually get nurses, doctors, and all the staff to sit down and talk about what they're going to do?
Right. Yeah, and to follow through and do it. Right. So that's and then hold them accountable with the reasonable measures, and so feeding them back the results. The other paradigm shift was after they leave the operating room, or actually just before they leave the operating room. For years, the anesthesia was, I call it snow and blow. Yeah. So snow and blow is we would give medications, whether it's opioids or other medications that knock people out, because we don't want them to, fear of them waking up during the surgery or different things like that. But we actually, our anesthesiologists were very on the ball and forward thinking, and actually came up with, how do we give the proper amount that doesn't overdo it? And we found that after surgery, instead of, just take it easy for a few days, that the quicker we get you back to your normal function, that restore you back. If you were mowing the lawn when you had your heart attack before you came in and got your CABG, then the sooner we can get you back to mowing the lawn afterwards is actually better for you, instead of just, take it easy for a month or two.
Yeah, it's almost if you rest, you rust. Yeah. It's about getting those patients up and making them part and parcel of that treatment regime that's there, but making it about the patient and incorporating all of those team members that are there.
So it came down to culture. Yeah. The culture, instead of strategy or short term, would have done goals, objective activities, but the culture was, what do we value? Well, we value getting this patient, getting this person back to their life. And so then what are the practices and behaviors that we want the doctors, the nurses, the physical therapists, the nutritionists to do? So then they were able to focus on that. So day one of surgery, instead of just laying there, you dangle your feet off the bed. Maybe you stand with assistant. You get your tubes and wires pulled at the appropriate time, and you get your gut working again with a smoothie or whatever nutrition that you can tolerate. And so that's a big change in healthcare, and it has to do with relying on culture, not on widget making.
And it's interesting because when we sat down and we started talking to the nurses and the doctors about it, it's things they always want to do, and often we find that the systems that are in place to protect patients and to progress them during any particular difficult time during their life within the hospital often tends to slow the process down and sort of staggers it. It happens, but it happens eventually. And having that cultural shift is not just focused on the clinical staff that's there, but it's working on the administrative staff as well to understand that these patients are going to progress because the patient's progressing, not because they're being pushed because a system is driving it forward or technology says this is day one, you should be at this stage. It's about the patient reaching their goals and having the patient aligned with what the clinical staff are looking to achieve, what the patient wants to achieve, and to help drive that forward.
Yeah, it's actually paradoxical, and sometimes it takes some explanation to leaders. Often the strategy that administrators have is beds and heads, but when it's actually, this patient is actually going to get better quicker and get back to their normal and get into their outpatient cardiac rehab, those are all good things. And then guess what? You can take care of another patient that has their time of need.
Yeah.
So using culture to change is going to have long-term effects.
Yes.
Short-term strategies were helpful in the game plan for CABG surgery and also for sepsis, but they made a huge difference when they were woven into the long-term cultural shift, and then the change lives on indefinitely.
No, I agree, and there's got to be a way of helping drive that change. There's got to be a way of keeping it moving and to keep that sustained element on there.
Yeah. Well, the change, it doesn't happen because of quarterly executive summits.
No.
It doesn't happen because of teams of consultants, piles of books, piles of data. Our change started with 3 people, maybe 3 nondescript people, 3 people in a nondescript office who used their creativity and who used a simple 8-step process.
That concludes today's episode of Transformative Healthcare, a limited edition 14-part podcast series. I've been your host, Todd Chobatar. To discover other great resources to help you feel whole in mind, body, and spirit, please visit us at AdventHealthPress.com. And while you're there, remember to sign up for our free newsletter that includes healthy living tips, leadership wisdom, and regular giveaways. Be sure to tune in for our next episode, where Jeffrey Kuhlman and Daniel Peach will be discussing 3 rebels in a corner, the chest pain project, and 8 proven steps that can change everything for good. Thanks for joining us.